Thank you, Dr. Harshali, for giving me this opportunity. I'll be talking to you on this topic, diabetic retinopathy and cataract, special considerations in retinal disease management to improve the visual outcome. So this is a scenario now that most of us would have faced. A patient now having diabetic retinopathy with some macular edema. OCT was normal and went ahead with the cataract surgery, and a few months later had a worsening of diabetic macular edema. You can also see NVD in the other eye. And this is another scenario where a patient with PDR managed with photocoagulation. One eye had a cataract. OCT showed a near normal looking fovea. And 3 weeks after the cataract surgery, patient came with further drop in vision. There is a vitreous hemorrhage in spite of a normal ultrasound preoperatively. So the question is, does cataract surgery lead to progression of diabetic retinopathy? The answer is both yes and no, because earlier the ETDR study showed that there is an increasing trend towards increasing retinopathy progression and worsening visual acuity. And also, large studies have shown that there is a progression of center involving macular edema following cataract surgery. But recent reports have said that if the cataract surgery is uncomplicated, then there's no significant progression of diabetic retinopathy, and that the generalized conclusion that phacoemulsification causes progression of retinopathy is not true. So I'm going to go through some of these situations and try and see how we can get the optimal results. Now let's take the first situation, NPDR without diabetic macular edema and cataract. So we could have two groups of patients. One, patients who are treatment naive macular, meaning in the sense they've not got any focal laser or anti-VEGF in the past. Or you have another situation where the patient has been treated and right now has a normal looking fovea, OCT showing a dry fovea with no central thickness. Now in the first instance, you can directly go ahead with the cataract surgery, and of course, as I said before, there could be a risk of progression, so you need to watch these patients post-operatively. In the second situation, there are two schools of thought. Some people believe that you should go ahead with the cataract surgery and then follow up the patients. But recently, this concept of prophylactic anti-VEGF therapy has come in, where investigators believe that if you give preoperative anti-VEGF in these patients, in spite of having a dry macula, these patients end up with less post-operative complications. The cataract surgery can be done 2 weeks after the injection. Because the studies have shown that even with no retinopathy, the risk of developing diabetic macular edema post-operatively is high, and this risk increases in the presence of any pre-existing retinopathy, and it is also directly proportional to the severity of the diabetic retinopathy. Now, with regard to progression of diabetic retinopathy also, these eyes, there is a possibility, especially if the surgery is complicated. So if you have a complicated cataract surgery, you could end up with some progression. There are certain high-risk groups that are identified, and studies have shown that its impact may persist even 5 years after surgery. So coming to the next situation, when you have NPDR with DME and cataract, this is how I would look at it. You look at the density of the cataract. If the view is poor, you could still do an OCT, as even Dr. Harshali showed. Even with the cataract, sometimes you get fairly reasonable OCT images. And if you find diabetic macular edema, it's because you cannot do a laser photocoagulation. It's better to do give an anti-VEGF and then plan an early cataract surgery in these patients. Now, if the cataract is not very dense and you have some reasonable view, and if you on the OCT you see a non-central edema, most likely you may get away by doing a focal laser, and then you can plan the cataract surgery subsequently. But if there is a central edema, you have to think of anti-VEGF steroids followed by cataract surgery. Now, what is the timing of cataract surgery after injection? Because of the short half-life of intravitreal agents, cataract surgery can be done at around 2 weeks after any injection. If you look at the large multicentric trial, the RISE and RIGHT data, surgery was done even at around 7 days after the injection, and they had good outcomes. Now, in patients with DME and not so dense cataract, many studies indicate that you need to wait for at least 6 months for the DME to stabilize, and this causes better post-operative outcomes. But this is not really feasible in clinical practice, and there are other investigators who believe that it's not ideal because maturation of the cataract can jeopardize the surgical safety as well as the monitoring of diabetic retinopathy. Now, the role of OCT, I think, has already been stressed by Dr. Harshali. It is very important not just to differentiate central and non-central diabetic macular edema, but a word of caution, because these images may not be of good quality because of the cataract. So when you comment on finer aspects of the OCT, you should be careful whether the quality of the image is good or not. Morphology of edema may be important because spongy edemas are known to have better outcomes than CME or SRFIs. If possible, if you have a reasonably good quality image, look for biomarkers. Some of these biomarkers have poor prognosis. Vitreomacular interface abnormalities, drill, ellipsoid zone loss, all this have been associated with poor outcomes. If you have hyperrefractive foci, we now tend to give more steroids in these eyes. In patients with ischemic diabetic macular edemas, the outcomes are poorer. We all know that. It's better to avoid macular laser photocoagulation in these eyes, and these eyes are better treated with anti-VEGF or steroids. Now, regarding the timing of anti-VEGF therapy, once you've decided to give an anti-VEGF therapy, when should you give the anti-VEGF therapy? It is best given before cataract surgery, because we have a large data from all the multicentric trials that if given before cataract surgery, they are less likely to demonstrate macular edema and diabetic retinopathy severity. There are also reports of anti-VEGF given in the perioperative period, that is at the time of cataract surgeon and immediately after the cataract surgery. So this is also an effective strategy to prevent postoperative worsening. We need to consider intravitreal steroids in certain situations. I think most of the people who give injections know this. When you need anti-VEGF more frequently, or when there is systemic side effects, or when you have some OCT findings like extensive hard exudates or hyperreflective foci, and of course in post-vitrectomy situations. Now I'll just touch upon PDR a bit. So we have two situations in untreated PDR with cataract. So through the cataract you make out there is some kind of a PDR like a picture, but then you are not able to grade the PDR well because of the cataract. You should do a B scan, rule out vitreous hemorrhage and macular TRD. If the above are negative, give an anti-VEGF injection and then plan the cataract surgery. There may be some situations where anti-VEGF is contraindicated. Then these patients know you need to do an early post-op examination and plan a very early PRP as early as 2 weeks. But if the view is reasonable, and if you could classify them as high-risk PDR, you give an anti-VEGF. If it's not high-risk PDR, try and do a PRP. The ETDR has said that PRP should be done before cataract surgery, and you should wait for at least 6 months of stability. And doing it just before cataract surgery should be avoided because of the increased risk of postoperative macular edema. Now the question is anti-VEGF better than PRP in these situations? The answer may be yes, because even in the non-cataract scenarios, the supremacy of anti-VEGF has been established. So this may be more relevant in cataract eyes because adequate PRP is not possible in these eyes. So definitely anti-VEGF scores over PRP. Now in a treated patient with PDR, when they come to us with cataract, the first thing we look at is the fundus viewable. And if you have reasonable view of the fundus with good PRP marks, and even if it is an extra macular traction, these are eyes which you can go ahead with the cataract surgery if you think cataract is the reason for the visual loss. But if you have persistent new vessels or preretinal hemorrhages in spite of a PRP, then you know it's inadequate. You need to do an add PRP or give an anti-VEGF. And obvious vitreous hemorrhage and macular TRDs need combined surgeries. Now, if you're unsure, because the clinical examination, because the cataract is not sure, you should do a B scan. B scan is normal, proceed to the cataract surgery. And if it is abnormal vitreous hemorrhage or TRD, you definitely need a combined surgery. There may be also other situations where anti-VEGF should be given in PDR eyes with cataract. This is especially before cataract and vitrectomy procedures because it prevents intraoperative and postoperative bleeding. When you have anterior segment new vessels or neovascular glaucoma associated, or even with the past history of treated new vessels, neovascular glaucoma, it's better to give anti-VEGF. And if there is PDR associated with diabetic macular edema. Postoperatively, these eyes need to be seen very frequently. The first examination can be as early as 1 week, 1 to 2 weeks. If necessary, you need to give an anti-VEGF, you can give it as early as 2 weeks. If PRP needs to be done, you can also do this as early as 2 weeks, but you need to do an LIO PRP. You also need to differentiate post-operatively. When a patient comes with macular edema, you need to differentiate the typical worsening of diabetic macular edema as against pseudophakic macular edema. So if when in doubt, do an FA, because FA shows the typical optic disc staining and the typical petaloid pooling. And the OCT gives you enough clues: hyperreflective foci, intraretinal hard exudates, turbid fluid. Turbid fluid is a sign that tells you that it's diabetic process. So the prognosis is generally good in these patients because nowadays the incidence of complications is less and they have better visual outcomes. But what is clearly established is that patients with mild and moderate NPDRs have good outcomes when compared to severe NPDR and PDRIs. And if you have macular problems, as mentioned there, most of these patients have a poor visual outcome. As Dr. Harshali again said, OCT is a great preoperative tool. So we think that this in a cataract OCT may not be good enough. It does pick up most of the changes. As she said, a quarter of patients with cataracts who come for cataract assessment will have some kind of maculopathy. So it is not just identifying the macular edema. You can also identify NVs, as you can see in the photograph there. NVs on the OCT that helps us to identify these problems early. In patients with dense cataract and diabetic retinopathy not gradable, we should do a gonioscopy, rule out the neovascular glaucomas or new NVI or NVI. Look at the other eye, often gives us a clue. Look at the records. They may carry records that the patient had PDR in the past. Take a good history, explain the prognosis, and these patients require early postoperative management. To conclude, early surgery is better, and the outcomes are better with mild and moderate NPDRs. You treat DME and PDR adequately prior to the cataract surgery whenever possible. When not possible, a postoperative close monitoring is required, especially in DME treated eyes and PDR eyes. And these patients, the postoperative management, either anti-VEGF or PRP, can be done as early as 7 to 14 days. You should know when to refer the case to a VR surgeon, and also should be able to differentiate pseudophakic macular edema from worsening diabetic macular edema. Thank you.
Thanks, Manoj. I just wanted one question, you were talking about anti-VEGF and steroids when patient is having coexistent cataract as well as DME. Do you consider the biomarkers to decide on what drug to give, or do you side with steroids when you are going for a cataract surgery along with the treatment?
Now, if the problem is getting a good OCT picture in the setting of a cataract, if I get a good OCT picture, I would definitely go look at the biomarker signs, and if there are a lot of hyperreflective foci, if I see a lot of turbid intraretinal fluid, then I think these are signs which tell me that steroids may be beneficial, because anyway we're going to remove the cataract. So this problem of steroid-induced cataract is not there. It's only the glaucoma. Otherwise, the patient is not a glaucomatous patient, has no risk for family history of glaucoma. Then I think I would use these signs to decide on steroids over anti-VEGF.
Does the audience have any question for Dr. Manoj, because he's going to leave after?
In mic or go?
Yes, sir. So regarding the coexistent use of cataract surgery with Ozurdex, sir, is it a normal procedure which is done, or do we really contemplate it? Because in our institute, we had one odd case in which anticipatory we had given Ozurdex like this, and the patient landed up with a delayed fungal end-off, and that eye was literally lost. So after that, this has become something like a norm. We have stopped even contemplating that for patients like...
I agree with you, 100% I agree. In our institute, we do not give either anti-VEGF or steroids during cataract surgery. We always do it pre-operatively.
Yes,
we convince the patient that it's better to do it pre-operatively. Even we had a bad instance with steroids.
Yes, sir.
So, but there are reports.
Yes.
If you look at the literature, there are people who are giving it. So I think for the sake of knowledge, yeah.
I have a counterpoint. In our hospital, we do it regularly.
Yes, sir.
Together at the end of the surgery, sometimes even we don't go. The cataracts themselves give.
Yes, sir.
Give
That
advice.
That is how we were also doing.
Actually, we had a study from one of our fellows during a fellowship. She did around 200 cases of concomitant same sitting injection and surgery. She looked at the risk of infection, postoperative, immediate first day postoperative IOP hike, and intraoperative any lens dislocation, iris prolapse complication after the injection. So there was no incidence. It was proved that it is quite safe to give. So probably just because you had one incident doesn't mean that it is bad.
I totally agreed, sir. I just wanted to highlight that point because we had faced that issue.
Right.
Thank you, sir.
Yeah, but Sarana, only my different opinion is only this. This is like for a general crowd, this can just be a carry-home message. That's the only thing.
The problem with our institute is most of our people are coming from outside the city. So calling them for frequent visits to give injection and then do surgery. So that's why we did this study to show, we wanted ourselves to be sure that we are not causing more harm.
Okay.
And somehow in our study we didn't have any untoward incidents.
Thank you.
There is no data to support or negate, so it's up to you to defend actually. There is no data or there's no recommendation that you should not do it together. So it's up to you to defend actually.
Physicians have made the patient fit with all investigations in the blood culture. So we are operating on a perfectly sterile eye or sterile ward. That means the fungus is coming from probably from outside. It's not a contaminated zoodex. It can never happen like that.
What you're saying, point is legal, valid point.
No, but sir, physician giving fitness and
We have never done that anyway. I just contemplate.
physician giving fitness and post-operative endophthalmitis, sir, that no, physician has no role there, sir.
No role there. That is why. Most of the patients are getting away with it. There's no problem. Probably 1 out of 10,000 or 1 lakh may develop, which is not due to Ozuridex. Not even otherwise they will get it.
Yes.